You should always be thinking about your next step. Because if you're not thinking about your next step, what are you? Behind, right? Okay.
Wait, so why aren't there more needle decompressions in the field then?
Because you don't have good paramedics. You guys are gonna be awesome when you get out there.
So actually, in follow-up to that question there, like, we don't really need a decompression unless we are, we get the key sign.
Correct.
You got your deviation, you got your subacute, the whole
down
yard.
this side will be.
So,
build the pressure.
if you are suspecting the fact that you have a CHF patient that has a spontaneous pneumo, it's not tension yet, I know we're not supposed to do it because it doesn't have signs, but is there something wrong with doing it sooner if you recognize it sooner? I'm not phrasing it well.
I know where you're going. No. Why not decompress a simple pneumo, basically is what you're asking.
Yeah,
So the idea is, so with a simple pneumo, right, you get, so you get this lung, right? It's starting to collapse. Do people live without partial lungs? Do people have lobes of their lungs removed? Do they survive and are they fine?
Yeah.
Do we need our full lung to work? Do we need this lung at all to work? So the idea with the needle decompression, why do we do the needle decompression? What is happening inside the thoracic cavity?
Pushing on the heart, pushing on the lungs.
It is causing the cardiovascular compromise, right? So that's why we don't decompress the simple pneumos, is because it has it crushed down on the heart, and we're still able to circulate, right? Because at 89%, is somebody getting enough oxygen to survive?
yeah.
Right? Some people,
Well, if they have
some people live on
COPD,
that
they're
89%.
probably
It's gonna drop pretty
low
quick.
already.
Right, so COPDer is probably low already, probably have a higher CO2 in their, or CO in their system. So it's just that kind of thought process of, you're thinking tension pneumo, you're ready for a tension pneumo. We have a lot of things that are pointing us close, like we're on the way there. Would you agree?
Yes.
Based on everything we see here? Would anybody disagree?
Unless I see
First thing-
his blood pressure suddenly drop and his heart rate start racing, I'm gonna withhold that decompression. Because once the blood pressure starts dropping and the heart rate starts going up, then you're probably forcing pressure on the heart.
But
Isn't
even
that what you're seeing?
But not dangerous levels yet.
but it
Are
is.
we shocky yet?
We're decompression. We're decompensating.
No,
So, hold on. So,
It's
coming back
compensating.
to our lung sounds.
It would be good pressure.
Where'd we go?
The second
decrease.
bottle.
Okay? So we have decreased breath sounds. So if we have decreased breath sounds on the right, is some of this lung still working?
Yes.
So has it completely gotten to the point where it's pushing on the heart yet?
No.
No, but is that interthoracic pressure increasing, do you think?
Yeah.
So we're getting to that point where it's like, okay, this may turn into a needle decompression. Like we're thinking, we're prepared,
Get the kid out.
and all that is all gonna depend on how big, so back to our sudden onset. Has this progressed to this in 5 minutes? Am I concerned if this progressed from point A to this in 5 minutes? Am I
Yes.
concerned?
Yes.
Yeah.
a big old.
Am I concerned if this is taking 24 hours to get to here?
No.
No, right? So that's what we're thinking about, getting those questions with that acute onset. Events happen right around it, will help paint that picture for you to be like, okay, this is what I'm thinking we got a simple potential pneumothorax going on here. Maybe we're progressing into the tension pneumothorax. It all just depends on what the onset, how long it took, and what the mechanism behind it was.
What's the first thing that you would notice when you know you're gonna have to go to a decompression at that point? If you have no lung sounds, or you're gonna see the trachea, or you're gonna see subacute burst, or vitals are gonna show?
So you may never get subacute emphysema,
Yeah, that's
Right.
really,
because a lot of times, so depending on where the injury is, so say you got a very distal alveoli that burst, right? So all that air has to slowly make its way up here, right? So you may never see that. Tracheal deviation, that's after this whole thing has pushed, gotten to the heart, gotten to your carina, and now has started. So you're completely gone here. So the first thing you're probably gonna notice before any of those signs is your lung sounds are gonna go away, right? So that's why you guys have to be the person that listens to lung sounds. Do not have someone else listen to lung sounds. Because you listen to lung sounds first, do your thing, do your check, and then 5 minutes later, okay, hey, weird. This person's looking a lot crappier. Pale, cool, diaphoretic now. My blood pressure's dropping a little bit, and you're the one who comes back and listens to lung sounds again. Because if somebody else listened and they had diminished, and now you listen and you're like, well, yeah, they sound diminished. Are they more diminished than they were? Where have we gone to?
So the first thing you should notice is lung sounds and vitals.
Yep.
You probably will never see, if you get to the point of seeing the other stuff. shit's
You
going down.
suck. You
Yeah.
suck at your job.
Okay.
If it's an onset like this, and we present like this, and you get to tracheal deviation before you realize that you are in attention pneumothorax, I failed you guys, okay? Like, you have to be able to recognize, and that's why we do trends on all patients. You're tracking how they are trending. That's why with patients like this, is this a every 10-minute vials or an every 5-minute vials? Because we have the potential to lose this person, like as in, get behind. Make sense? Tracking?
If they could get to that point despite your interventions, because you're gonna wait until there's cardiovascular compromise before you solve the problem of decompressing.
Right, but do we want to hang out and wait 10 minutes for somebody to go from 98/62 down to 60/40? Or do we want to hang out and at 5-minute mark and we catch somebody that goes from 98/62 and is now 80/60? You want to catch them before you are way behind, right? So that's why we're trending. We're watching this happen and we're like, okay, We're like, okay, yep, there goes the blood pressure. Yep, hey buddy, you're dying pretty much in front of us. This is what we're gonna do. And you're gonna prep the person and be like, hey, if this progresses, this is what we're gonna do. This is what I'm thinking is going on with you. You have air trapped in your chest. The only way to get it out is to put a needle. And they're like, what? I'm just like, hey, let me show you the needle. It's like this long, right in your chest. Have you seen Pulp Fiction? That's kind of what it seems like, right? Not really, but you are talking to the person, explaining kind of what you're thinking and what's going on. Some of these people have had this before. Somebody did a good job asking, hey, have you ever had this before? A lot of COPD patients have had spontaneous pneumos that are able to heal themselves. Okay?
Can we talk about this blood pressure that's current,
Sure.
98/62 with that high heart rate?
Yes?
That, to me, looks surprising. It doesn't look like it fits my patient. 52, COPD, I wouldn't expect to have that low of a blood pressure, especially with that high of a heart rate. So with those signs right there, am I already thinking that it's that low because it's starting to tension?
So what does our body do first? Works to
Tries to
compensate, right?
compensate, yeah.
So depending on what this person's history is, and related to what their normal blood pressure is, yes, I would expect their blood pressure to be higher. So, of all the things that we have, all the red flags that are going on, we have a ton of red flags that are telling us, be ready, be ready, be ready, be ready, right? So this is an absolute thing, like we're heading the wrong direction here, right? We're heading, like this patient's gonna have cardiovascular compromise. Like everything here is telling us cardiovascular compromise is on the brink.
Yeah.
Okay, so this is the one where new paramedic students have a hard time. They see this, and most are really like, okay, we're okay here. Yeah, 89%. Yeah, we'll give you a nasal cannula, right? A little diminished lung sounds. Yeah, it's normal for COPD. So new paramedics, people that haven't been around patients that present like this, get very complacent with these types of patients. All right? They're unable to recognize sick versus not sick. So that's why you guys did an awesome job just reading this first thing right off the bat, and you guys are like sick, right? So they get in this complacent, like, oh, okay, yeah, chronic COPD or short of breath, yep, here we go. And they skip a lot of those acute onsets, OBQRSTs, that build that picture and your argument for sick versus not sick, right? Even if you walk in thinking not sick, if you ask the right questions, you're gonna find yourself sick. Okay? All right. Man, we are just, this is a great slide, I can see. We made it to one slide. Go ahead.
If this patient was in a lot of pain, would you give pain medication, or is there any reason why you wouldn't?
No. So, like with our acute pain management treatment protocol, you have the ability to give fentanyl morphine at any point. Do we want to give morphine to this person?
No.
Do we want to give fentanyl to this person?
No.
Maybe more than morphine.
Am I gonna give this person fentanyl? Why am I not gonna give this person fentanyl?
When you rated your pain, it admitted to you.
Okay, why else so?
There's respiratory disease, blood pressure.
So what do you think's gonna happen if you get more and more air in your intrathoracic cavity? What's gonna happen?
Blood pressure's gonna
Feel-
drop,
More pain.
and
You'll
the
know it's getting
respiratory-
worse.
So you're,
What do you say? I heard it.
he'll complain more pain if it gets worse. So you want to know when that pain gets worse.
So the pain will increase because you have increased intrathoracic pressure affecting more nerves, right? So right now it's patient's tolerable, right? So what I'm gonna do is I'm gonna not give pain meds because I wanna know when this person's, hey, this pain's getting worse. Like, oh, okay, here's the needle. Take a look, how's your pain now? Better? You don't even gotta give fentanyl, you just show them the needle. It's like, if your pain keeps getting worse, you get the needle. You're like, I'm pain-free, allergic, hey.
But
Right? So it's that kind of thought process of making sure you're like, okay, what is my pain management going to do? Yeah, it's gonna make them more comfortable, but what does it take away from me? It takes away some of my assessment skills. And so that's why, like the whole coming in with a paralyzed patient, when you RSI somebody, that's why the neurologist is like, you gave a long-term paralytic. It takes away their assessment skills, right? So right now, you're the neurologist, trying to keep your assessment skills in play because you have a critically potential sick person. Make sense?
But once you pull the trigger to needle, then you potentially give fentanyl before you needle them.
If you are pulling the trigger to needle somebody,
No, I mean that way.
you don't have the time
Yeah, that's a good
to
point.
give the fentanyl. Unless you were super awesome and totally prepared and you've been like on the ball, Johnny on the spot the whole time. Which isn't gonna happen because you're gonna be busy doing this and that and
Yeah.
that, right?
Gotcha.
And so, yeah, in retrospect, you can give pain meds after the fact if you need to. But most of the time, if you get to a cardiovascular compromise at all with somebody that you're needling somebody, pain meds are the last thing on your mind or on their mind.
Yeah.
Because if with cardiovascular compromise, what happens to the LOC?
Just dropping
It's gonna go down because what's not perfusing,
the brain.
Brain.
right? So those are all the things that you're gonna think about as you do it. So, can I move to the next slide now? All right. Okay, so our treatment for this, holy moly, we talked about oxygen, we talked about that, we pretty much beat this one left and right. So, we know how to needle decompress, yes?
Yes.
So if this progresses, yep, it does its thing, patient goes cardiovascular compromise, we're gonna needle decompress, yes?
Yes.
Does everybody agree? If this person gets worse, we're gonna needle decompress this person?
Yes.
Anybody disagree? I'm just kidding, I'm totally. Okay, yes?
So when we needle decompress, is our only option gonna be mid-clavicular, second intercostal?
Just above the third line, making sure not to hit the additional vessels that are there.
Right.
Slightly nicking the third rib up and over with the bevel down, making sure not to just jam it right in the rib. Exactly like that,
Yeah.
yeah? Yes, that's our only option here.
Okay.
And why is that? When do we use our alternate site? When there's anterior trauma related to your first primary site. Does this person have an issue that's blocking
No.
their first anterior site? No? Okay. Can everybody find the second intercostal space just above the third rib on the person next to you? Really easy to find it on yourself. Does everybody remember the landmarks that we use? What landmarks do we use? Josh? The angle of Louis. And what do you do with the angle of Louis?
Oh, yeah.
Janae?
It's like a good what?
What do you do with the angle of Louis?
I was not here.
Holy moly, okay. Maddie? What do we do with the
Found
angle of
it.
Louis?
Angle of Louis two.
And one more down. So you're like right.
Is it angle of Louis
And
two?
then angle so you go below
I'm
that.
gonna go crawl in
Angle of
a
Louis
corner
two.
and hide.
Because then from
James.
Louis go three.
What do we do with the angle of Louis? Let's see if we can go over three.
Second
Go
intercostal.
over what is on the left, so go left over about 3 or 4 inches, depending on how big this guy is.
In
And
line
then
with
start feeling down from the clavicle down.
Pressed on.
That's not.
Oh, better be joking left and right.
We do our forward. We go
Okay, with a show of hands, who here knows what to do with the angle of Louis?
Move to the left. That's
Move in line.
intercostal space.
Find it?
Amanda, did you raise your hand?
After that.
Yes,
I thought I saw your hand back there. What do we do with the angle of Louis?
you follow it down and then you follow it across to the
Find the
mid-clavicular
ankle. And then
line.
What does the angle of Louis do to you?
put you on the second intercostal.
It
Yes.
puts you in this, so, angle of Louis, laterally, whichever side you're going on, okay? Find that rib. As soon as you push down on the rib, that puts you into the second intercostal space. Is that where we want to stick the needle?
Yes.
Well, more mid-clavicular.
So instead of going 1 to 2 inches, right, James?
And
Nice terminology, we always use good terminology. Mid-clavicular line, second intercostal space, just above the third rib. Bevel down, up and over the third rib, making sure to stay away from the blood vessels that are located at the bottom of the second rib. Boom, we got our needle. Yes?
Yeah.
We go through. What do we do then?
Take out the stylet.
Take the stylet out. Then what?
Suck the air out.
That's how we do mouth
Mouth the lung.
Taste it, see if there's fluid.
Yep. Gotta check to make sure there's any blood, right? Can we put a 10 cc syringe with saline on the end of it, on the back of it, as we go through? What's the idea behind that?
You get bubbles.
Bubbles.
You'll get bubbles if you have enough pressure, right? Will you always, if there's air trapped in there and you have fluid in your syringe, will you always get bubbles?
No.
Why? Because of the pressure, right? So you'll get a lot of people in the field that are gonna tell you, hey, put one with fluid on there, right? You don't need to do that. If you just put a regular 10 cc syringe on there, and as you are going in, just like when we're cranking somebody, if you put just a little bit of back pressure on it as you're going in, as soon as you get into that air cavity, you're gonna draw air, right? Draw your air, advance your catheter, pull your needle. I told you about my partner that left the needle in, right? Give
No.
us- yeah, first time that he or I had ever done this, had a year of experience combined between the two of us. And we did needle decompression, do it on a quad, went over like a 40-foot embankment quad, one of the big 4-wheel drive quads, landed on top of them, crushed chest wall, complete absent lung sounds, like textbook tension pneumothorax. And
Both
we're like,
sides?
"Man." Huh?
Both sides?
Just one side, just one side. So he's like, I'm gonna needle decompress this person. I'm like, sweet, let's do this. And so we're excited. We got like 6 months of experience. And we're like, yeah, let's do this. And we're like 25 miles from the hospital. Before the days of being able to fly somebody. This is when you had to do stuff in the back of the ambulance. And so he needle decompresses. And I'm sitting there, I'm like, yeah, that looks good. Cause I'm like, yeah, we got second intercostal space. And I'm like narrating it in my head, like, yeah, we got this. And he's just like, and so, I'll show you guys, there's a little back cap that comes off, right? So that little black cap can come off. So he pulls that little back cap off. And that's the thing that basically allows blood to free flow out of those catheters, right? So I'm watching and he pulls that off, he's like, yeah. There's like no wish of air. I'm like, well, okay, must not be a tension, must be a chemo or something. And so we transport, right? We do our whole thing. And we get to the ER, and the surgeon's there, and the surgeon walks up and is just like, listen to lung sounds, like, huh, that's weird. And we're standing there, and it's funny because my partner was super cocky. And he's like, yeah, we need a needle decompression. And the surgeon goes like this, and like puts his hands on his hips, looks over at us. He's like, really, guys? He reaches over and he pulls the needle out of the catheter, and it's just like, and like fluid, like the high pressure fluid, and like instantly you see the lung capacity just is like. And I'm just like, he did it. It wasn't me. I didn't do it. I had nothing to do with it. And so it's one of those great like learning moments where I'm just like, oh, I've got to pass this on to everybody I know. Don't do this, right? So that's why you got to really, because the first time you stick this giant needle in somebody's chest, you're nervous. I'll be honest, you are nervous, right? Because think about it. Like, look at the second intercostal space. Mid-clavicular line. How close to the heart do you think that is? With a needle that's this long. I'm like, in my head, I'm running through it, and I'm just like, aorta, okay,
Arch.
Yep, we got, aortic arch, yep, there's a lot of vessels there. Yeah, there's no reason, I mean, they wouldn't give a paramedic this kind of a thing to be able to do if I could kill someone, right? Like the whole time you're running through that kind of thing in your head, like, here comes this giant, because the needles are long. Like,
They're big.
skinny people, you can probably stick it out their back. Like totally harpoon them kind of thing. And so you're just like, okay, and then you go to do it, and boom, you run it right into the rib. You're like, so what you gotta do, pull it back out, oh, let's try again. So then you gotta really get that finger up and over the rib, and okay. So that's why, like when I do it, I take it, and I put the needle just above my finger, right? And so then I can feel it as I'm going up and over. So I go, get up like that, up and over, and I slide my hand down, and then that's how.
You bury the whole needle, or do you do it like a IV where you
Get a flash.
So as
Get
soon
it
as, so as soon as I
in
get
and-
air, as soon as I get air, right? So boom, and it goes. I get my air. I advance it about that much farther, and then I hold the needle, advance the catheter off, bury the catheter all the way in, pull my needle out.
Sorry, how much do you advance it?
About that one.
after you get air.
After you get air, yep. Because same kind of thing. You want to make sure
Right.
you're totally in,
In
the
the
cavity
cavity.
and you're in the right cavity, right? So we do need a little decompression on this person, right? Yeah. Everybody agree we want to do that?
Yep.
Yeah. What do we do then?
Put a flapper.
Okay, so the flapper days are gone. We're not doing flappers anymore. So there's enough, so everybody understand what a flapper is, one-way valve.
Yeah.
Basically it keeps air from going in and out. Basically they're saying now that there's not enough air that travels back and forth, and it's an open valve that basically it allows the air to escape in and out, and it self-regulates itself. We used to do Heimlich valves. Used to take a glove, cut the glove off, put that over so it would collapse on inhalation. So as they breathe in, it collapses, not allowing air, and then as they exhale, it opens it up and allows air to escape. And so basically it's just an open valve now. They've thrown the valves out the window, saying that there's not enough air movement and trapping that occurs.
Is that the same with occlusive dressings?
No, well, same concept.
Because ours don't have a valve on it anymore.
Your what?
Occlusive dressing.
Occlusive dressings don't, so occlusive dressings are a tape 3 sides allowing air to escape, and that's like a giant sucky chest wound.
Right.
So with that,
Is that not just a one-way valve? You're creating a one-way
you're
valve.
creating a one-way valve. But think about it, so you put occlusive dressing versus a small needle hole, right? So the occlusive dressing is going over a giant hole. So the idea with putting the one-way valve on is there is a big enough hole here to allow air to move in and out. So you have to prevent the air from the sucking chest wound part, right? So as they inhale, they don't want to suck all that extra thoracic air in.
Okay.
Makes
But
sense?
it's not gonna be through the catheter.
Right. Catheter is small enough that there's not enough air movement to start trapping. Whew, yeah? Sweet. Second intercostal space. Yep, went through that, got that, boom, boom. That's what it looks like. Ah, it looks amazing. Just above the third rib.
Will you go back to that picture?
Keys for those,
Yeah,
like
I wanna look at all those.
So the catheter size is all dependent on what your protocols are. Okay? So they're roughly 10, 12, or 14 gauge. Oh, which way?
That.
That one?
Yeah.
That one, that one, that one, that one, that one, that one. And so 10 gauge, 12 gauge, 14 gauge. The big thing is they have to be long, okay? You need the long 3.5-inch needles or longer to be able to do them, unless you're running a pediatric. And if you're going with a needle decompression in pediatric, usually you bump down to an 18 gauge. Normal length catheters are sufficient for those. The big thing is with needle decompression needles, in order to do it properly with the syringe and everything like that, you can't use the new safety needles, right? They're not designed to hook a syringe onto, most of them. So you have to specifically buy these special, straight, old school catheters, and it's funny now because now everybody knows that, and so they make special needle decompression needles, which are 10 times the price of a straight catheter. Like you get a box of straight catheters, 14 gauge catheters, and it's like $10, right? One of those special needles packaged all by itself in the little special container is like $10 by itself, right? So the industry has realized that and they've capitalized off it. Okay.
Of course.
In the wrong business.
All right, so,
Seriously.
so secondary site for needle decompression is,
Secondary site?
secondary site, say this is anterior site's done.
Intercostal?
Axillary.
Fifth
Fourth.
intercostal? Fifth intercostal? Fourth?
Fourth intercostal space mid axillary?
Axillary.
Anterior,
Axillary.
anterior axillary, okay?
Okay.
So remember the way to find it? Boom, up to the armpit, spread your, like that, okay? So up in here, you go right in the crick, right in the corner of your hand. That's gonna put you in the anterior portion of the axillary, so your anterior axillary,
Wait, okay. so
right in
then-
between your pinky
Tickly
and your
spot.
ring finger. So right in this spot right here is what you're shooting for, okay?
You're not spreading all your fingers.
No, I'm trying not to spread all my fingers.
For every patient?
Huh?
For every patient?
On a general adult. Pediatrics, you're actually gonna have to count down and,
Is it the
I
fourth
don't
or the?
understand how that's anterior.
Anterior is the front.
I know, but
front
it's
half.
going back,
Here's your mid axillary,
yeah?
okay?
It's gonna
right?
be on this side.
Here's
So it's gonna be
your,
on the front side because you're running all the way up into the crick,
Okay,
okay? So,
oh, okay.
so see there, so my axillary is midline,
Yeah,
so now I move forward about that far,
okay,
because the whole length is about like that.
Yeah.
So you're going in the anterior portion.
okay.
Okay, let's see,
that's
where we at?
fourth in our
How about, take a quick break?
V6 goes on fifth.